Hello everyone, welcome to the module in the cardiovascular system. In this module, we will talk about one of the most important parts of cardiovascular physiology and is integrated with medicine, that is ECG or EKG basics. Okay, so let me take you to this diagram of electrocardiogram, and in this diagram we will talk about the conduction pathway and the pacemaker rates and the speed of conduction. Okay, so let me just start with the conduction pathway. Now in conduction pathway, the primary pacemaker is the SA node. That means the electrical impulses are generated from the SA node. Now where is SA node located? SA node is located between the superior vena cava and in the right atrium. Okay, so it is located at the junction of superior vena cava and right atrium. Now from the SA node, the impulses travels to the atria. Okay, so it travels to the atrium, that is the left and the right atrium, and then from the atria it travels to the AV node. Okay, it travels to the AV node, that is the atrioventricular node. SA node is the sinoatrial node. So from SA node to atria, from atria to AV node, and from the AV node it goes into the bundle of His, right? From the bundle of His, the electrical impulses are transmitted to the right and left bundle branches. So it is transmitted to the right and left bundle branches. Is this clear? Now let me just add on to one point that the left bundle branch gets divided into two fascicles. Okay, that is the anterior fascicle and the posterior fascicle. Is this clear? Now the SA node, as I told you, is located at the junction of the right atrium and the superior vena cava and is inherent dominance with slow phase of upstroke. Okay, so this slow phase of upstroke or depolarization, that is the slow depolarization that we have discussed in pacemaker potential, is an aspect which creates autorhythmicity. I again repeat, it is the slow depolarization phase, that is the phase 4 of pacemaker action potential, is responsible for the autorhythmicity of the SA node. Am I clear? Now talking about the AV node, which is located in the posterior inferior part of the interatrial septum. It is located in the posterior inferior part and the blood supply is usually from the right coronary artery. Now why is it usually? Since the right coronary artery might be a part of the right dominant circulation. Okay, so hence it is usually a part, hence it usually supplies the AV node. If it is a left dominant circulation, it can be a part of left circumflex artery as well. Okay, now the blood supply is usually from the right coronary artery, and one of the most important part is there is a 100 millisecond delay for ventricular filling. Okay, remember that. So there is a 100 millisecond delay for ventricular filling. Now which pacemaker beats at a faster rate and which pacemakers beat at a slower rate? I'll just talk about that. Okay, so the SA node beats at the maximal rate and hence has the highest pacemaker rate. After the SA node, it is AV node. After the AV node, it is the bundle of His and the Purkinje fibers. Am I clear? Whereas the speed of conduction and the pacemaker rates are two different parts. The speed of conduction is dependent upon the different kinds of fascicles present. Okay, so the speed of conduction in SA node is not maximum even if the pacemaker rate is maximum. Okay, so remember that the speed of conduction is maximum in Purkinje fibers, then in the atria, then in the ventricle, then in the bundle of His, where this is missing over here, it is in the bundle of His and then AV node. So you can remember that as basically PAVAV. Okay, so Purkinje fibers, atria, ventricle and the AV node. Is this clear? Now let me just give you one extra point of information in this, that the sum of all the electrical impulses that are calculated on the various leads of the electrocardiogram, that is all the 12 leads of the electrocardiogram, the sum is in this direction. Okay, so this is the resultant vector of the electrical impulses. Is this clear? Now let us go to the graphical representation of the electrocardiogram. Okay, so in the graphical representation, each big box, that is 5 millimeters, corresponds to 0.02 seconds. Okay, and each big box vertically corresponds to 0.5 millivolt. Am I clear? Now, talking about the various components of the ECG, that is the P wave, the QRS complex, the T wave, and the U wave. Okay, now eventually producing PR segment, ST segment, and QT interval. Okay, there is one more segment or the interval that we call as RR interval, which determines the heart rate of a person. Is this clear? Now let's talk about the P wave. P wave is the first upstroke. Okay, now this upstroke is majorly due to atrial depolarization or atrial contraction. Now when just after P wave depolarization or the atrial depolarization, there is atrial contraction. Is this clear? Now talking about after P wave and between the R wave, that is the PR interval or the PR segment. The PR segment is the smaller segment. Okay, it is the end of the P wave and the start of the Q wave, whereas the PR interval is between the start of the P wave to the start of the R wave. Okay, so talking about the PR interval basically signifies the atrial depolarization. Okay, and it is till the point of starting of the ventricular depolarization. Is this clear? Now the normal length of PR interval is around about 120 to 200 milliseconds. Okay, so if the PR interval is elongated, which happens in multiple uses of anti-arrhythmic drugs, there is elongation of PR interval. Is this clear? Now talking about the QRS complex, that is a descent in the Q wave, then a rapid upstroke in the R wave, and then again a fallback in the S wave, that is a QRS complex. Now the QRS complex majorly signifies the ventricular depolarization. Now one part of QRS complex is the atrial repolarization is masked by ventricular depolarization, hence it is not shown in the ECG. Am I clear? So the atrial repolarization is masked by ventricular depolarization. Please remember that. Now the QRS interval is normally less than 100 milliseconds. Okay, talking about the QT interval, which is one of the most important intervals that is again affected by different types of anti-arrhythmic drugs. The QT interval signifies ventricular depolarization and mechanical contractions of ventricle. Okay, and followed by ventricular repolarization. So there is this ventricular depolarization, this is ventricular contraction and ventricular repolarization. Is this clear? Because the T wave signifies ventricular repolarization, the QRS complex signifies the ventricular depolarization, and the ST segment, okay, the ST segment signifies contraction of the ventricles. Am I clear? Now ST segment is the isoelectric phase. There is no change in the electrical impulse. Is this clear? And so is the PR segment. Now talking about the T wave is usually inverted in one or two conditions, that is ischemia or recent myocardial infarction. So the primary basics of diagnosis of myocardial infarction within the first few hours is not troponin I or CKMB. It is ECG. So please remember, ECG is the primary diagnostic of myocardial infarction in the first few hours. Is this clear? Now talking about the J point. J point is the junction between the QRS complex and the ST segment. So it is a junction between QRS complex and the ST segment. Now the ST segment, as I told you, is a isoelectric segment. Now talking about one more important wave, that is the U wave, which might or might not be present, but it is definitely prominent and significant in two conditions, that is hypokalemia, that means decrease in the potassium concentration, and bradycardia. Is this clear? So this is the basic outlook of ECG on the graph or the electrocardiograph. Is this clear? So this is all about the ECG or EKG basics. We'll talk more about it in different anomalies of electrocardiogram. Thank you for watching this video. If you enjoyed the video, please click on the like button and do subscribe to this channel. Let me know in the comment section below which topics do you want me to explain. Thank you.